This video is on causes of hypercalcemia, and I already have listed the main causes of hypercalcemia in veterinary medicine as well as a mnemonic to remember those causes. So first, with granulomatous disease, in some types of severe systemic granulomatous disease, the macrophages produce and release vitamin D, and this vitamin D causes increased intestinal absorption of calcium, increased resorption from bone, and then also increased resorption by the renal tubules. So it's not all types of granulomatous inflammation. It does tend to be the more severe or systemic forms of granulomatous inflammation. And usually we see that with like fungal infections or parasitic disease. So systemic blastomycosis, histoplasmosis, or pitheosis, as well as systemic leishmaniasis. Now, further support for granulomatous disease, at least in the ClinPath data, would include a chronic inflammatory leukogram, and then perhaps there may or may not be a hyperphosphatemia as well. Osteolytic disease can be caused by osteosarcoma, which is a neoplastic proliferation of osteoblasts, or by multiple myeloma, which is a neoplastic proliferation of plasma cells within the bone. With osteosarcoma, the osteoblasts can produce and release alkaline phosphatase, so you might see an increased ALP activity on the serum chemistry. And the neoplastic plasma cells in multiple myeloma often produce lots and lots of immunoglobulins, so you'll have a hyperglobulinemia and a monoclonal gammopathy. The spurious cause of hypercalcemia we're not going to address in this class. At least all of the cases that you'll get in the cases and on exams will be a pathologic hypercalcemia, so you can ignore that for now. So on to hyperparathyroidism. This is a neoplastic proliferation of the parathyroid cells. So this is either an adenoma or a carcinoma of the parathyroid. And this tends to occur in dogs. Now with this parathyroid neoplasm, it's producing and releasing lots of PTH. So not only will you get hypercalcemia, but a lot of the cases you'll see hypophosphatemia as well. The phosphorus could also be normal, but you wouldn't expect a phosphorus to be increased with hyperparathyroidism. Other changes you might see include an increased ALP activity, and that again is because the PTH stimulates bone resorption. Other changes you might see is a low urine-specific gravity for the species, so less than 1030 in the dog. And that's because the hypercalcemia causes a nephrogenic diabetes insipidus. So to confirm hyperparathyroidism, you can measure the PTH concentration in blood, and in these cases it will either be normal or increased. And most of the cases are actually within normal limits, but it should not be low. So PTH should not be low with hyperparathyroidism. Vitamin D toxicity can occur with some rodenticide poisonings or with ingestion of ergocalciferol containing plants. Now, vitamin D increases calcium and phosphorus, so you'd expect to see hypercalcemia and concurrent hyperphosphatemia, and this tends to cause a very severe hypercalcemia and severe hyperphosphatemia. So severe that if you multiplied the result for the calcium by the result for the phosphorus, it would be much, much, much greater than 70. And I use 70 because 70 is a special number. If the calcium times phosphorus product gets greater than 70 over a prolonged period of time, then calcium and phosphorus can spontaneously combine and precipitate out of tissues. When it occurs, that is called metastatic mineralization. So much calcium, so much phosphorus, they're spontaneously binding and precipitating out of tissues. So this occurs in various different tissues throughout the body with vitamin D toxicity. So you'll see multisystemic organ injury and failure. So you'll see renal failure, and also it can deposit in the alveoli and cause decreased gas exchange. But it does mess up various organs and tissues throughout the body. So Addison's disease or hypoadrenocorticism, this is due to an immune-mediated destruction of the adrenal glands. And this most commonly occurs in dogs, and it results in a deficiency of both cortisol and aldosterone. So the ClinPath changes that we see are due to either cortisol deficiency or aldosterone deficiency. If there's less cortisol, then you do not see a stress leukogram, so you will not have a lymphopenia, or you might get a lymphocytosis or an eosinophilia, but the most common thing is lack of a stress leukogram. And then cortisol acts to increase energy in the blood. So if you have a cortisol deficiency, then you'll have less energy in blood, and by that I mean less glucose, less cholesterol. The lower aldosterone concentration, you'll see the characteristic pattern of low, high, low. So low sodium, high potassium, low chloride. And that's because aldosterone normally acts to resorb sodium chloride and water from the ultrafiltrate and excrete potassium. So if there's a deficiency of an aldosterone, you'll see the reverse. Less sodium chloride resorption and less potassium excretion. Now, because there's less water resorption, then you would also expect to see inadequately concentrated urine. With renal failure, the hypercalcemia, or the mechanism of the hypercalcemia, depends on the species. So in horses, calcium absorption from the diet does not depend on vitamin D. The horses readily resorb or absorb calcium from the diet, so there's lots and lots of calcium in the blood. So the kidneys are primarily responsible for excreting calcium in the urine. And that's why you see lots of calcium carbonate crystals in horses normally, because there's lots of calcium in the urine. So if there's renal failure, there's a decreased GFR and therefore increased calcium in blood because less blood is being filtered by the kidneys. Now, the phosphorus in horses can be variable. Usually you see a low phosphorus because there's renal loss of phosphorus, but sometimes you can get hyperphosphatemia due to a decreased GFR. In non-horse species, there can also be hypercalcemia with renal failure, but the mechanism is different. So in these non-horse species, there's less excretion of uremic acids, and these uremic acids tend to be negatively charged. So these negatively charged substances bind the positively charged calcium in blood. So it actually increases the non-protein bound fraction of calcium in blood. In non-horse species, you also tend to get a hyperphosphatemia, and that's due to decreased GFR. So now on to the neoplastic causes of hypercalcemia, in addition to the osteolytic diseases that we already talked about. So some neoplasms can secrete PTHrP, and again, that's some types of lymphoma and some carcinomas, specifically T-cell lymphomas and apocrine gland adenocarcinomas of the anal sac. So with this increased PTHrP, you'll have hypercalcemia, and because PTHrP acts like PTH, you can also get hypophosphatemia. But not all the time. Sometimes the phosphorus remains within the reference intervals, but you certainly wouldn't expect an increased phosphorus. The other cause of hypercalcemia with neoplasms include monoclonal gammopathies, and not all monoclonal gammopathies, but some monoclonal gammopathies where the neoplastic immunoglobulin clones are negatively charged. So some lymphomas, some multiple myelomas can produce negatively charged immunoglobulins, which then bind to that positively charged calcium and cause an increase in the protein-bound fraction in blood. So those are the main causes of hypercalcemia, and gosh darn is the way to remember the main causes. In general, in practice, we primarily see neoplasia or renal failure as our primary causes in small animal practice, but certainly any of these causes are possible for this course or out in practice.